Welcome back. We are going to start with NSTEMI unstable angina treatment. Let us start the discussion. So I've checked it and everything looks perfect. I want to just check the recording that has to be uploaded. So that's fine, not a problem. Okay, we'll wait for people to join a bit. Yes, there are 100 plus participants now, so we can start the class. Okay. So as far as the NST ACS is concerned, the initial treatment is going to be the same. Like whatever we have discussed in the triaging phase, whatever discussed in the early stabilization phase, that's going to be the same. That's not going to change as far as NST ACS is concerned or ST ACS is concerned. But more importantly, what we are going to start in the beginning is the heparin. That's the most important treatment. But even more than that, your risk stratification as far as NST ACS is very important. You have to tell what is the risk of the patient, whether the patient is having a low risk or intermediate risk or high risk. But in general, let us categorize the patient into two. One is the low risk patient and second is the high risk patient. There are a few patients which come in the intermediate category also, but don't worry about that. Low risk and high risk. So how will you classify low risk versus high risk? You have something called a TIMI score. TIMI score. Based on this only, I'm going to tell whether the patient is having a low risk or a high risk. So as far as the TIMI score is concerned, if the score is more than or equal to 3, can anyone expand what do you mean by TIMI? I mean, people should be able to expand because there are certain few postgraduates are also here. So you need to tell what do you mean by TIMI. That's TIMI risk score. That is thrombolysis in myocardial infarction. That's TIMI. That's a group that gives this kind of score. Even you have a TIMI score for STEMI, but it's very famous for NSTEMI unstable angina compared to that of a STEMI. So if it's less than or equal to 2, you're going to call it as a low risk. And if it's more than or equal to 3, you're going to call it as a high risk. It's a TIMI high risk. Then you have something called a gray score. Can anyone tell what do you mean by gray score? GRAC, gray score. That is nothing but global registry for acute coronary events. So that's what we call it as GRACE score. Supposedly, if the GRACE score is more than or equal to 109, generally we call it as a high risk. If it's less than or equal to 108, we call it as a low risk. The same high risk patients can be categorized into two basically. One is called conservative strategy, then is called invasive strategy. So whenever the patient is having a low risk, it's very sure that you can go for a conservative strategy. Whenever the patient is having a high risk, then you can think about an invasive strategy. So first of all, we need to know what do you mean by conservative and what do you mean by invasive strategy. Conservative means you're going to just treat with medical management, like for example, heparin or GP2B3 inhibitors, whatever it is, you're going to treat only conservatively. As far as invasive strategy is concerned, I'm going to use a coronary angiogram here. That's what we refer to as an invasive strategy. Clear? So there are two types of invasive strategy. One is called an early invasive strategy where you do coronary angiogram within 24 hours. That's called an early invasive strategy. Then you have something called a delayed invasive strategy where you can do coronary angiogram within 72 hours. But you can do after 24 hours. But anyways, you have to do within 72 hours, which is really, really important. That's a delayed invasive strategy. And there's something also called an urgent angiography, which I'll be discussing in some time. So as far as the early invasive strategy is concerned, you can prefer if the patient is at very high risk, if the TIMI score is more than or equal to 3, or if the gray score is more than 140. So in this setting, you can really try an early invasive strategy. Low, intermediate, high risk were discussed for before for ST-ACS. No. Low, intermediate, high risk we have discussed. It's for CAD. So remember that you're doing an emergency before the diagnosis of coronary artery disease. So this low risk, intermediate risk, and high risk, what you have discussed is to tell whether the patient is probably having an acute coronary syndrome or not, whether the chest pain is high risk or not. So that is why we categorize that initially. So that is an emergency department kind of a categorization. You should not really confuse that with because there's going to be many other categories where you're going to use low risk, high risk, and all this stuff. what is the thing you're going to ask about two values, 109 and 140? Let me come back to that. So if you want to have an early invasive strategy within 24 hours, the gray score is more than 140, that becomes a very perfect indication. Suppose if the gray score is in the range of 109 to 140, then in this setting, you can consider doing a delayed angiography. In the sense, like, there is no, like early angiography needed, and there are multiple trials that substantiate this information, substantiate this data as well. Clear? So this is what you're going to do. Fine. So before that, you need to know what do you mean by TIMI score in the first place. When you call it as what are the category and things that are in the TIMI score? This is a multiple times asked question. So there are 7 points basically in TIMI score. So you can classify into 2. So either based on the history or either based on the presentation, what the patient is having. So what are the history related points that the TIMI score is going to tell? One is the age more than or equal to 65 years, which is the high risk category, it carries 1 point. Then apart from that, you have risk factors for CAD. At least if you have 3 risk factors for coronary artery disease. What are the major risk factors for CAD? It is the diabetes, hypertension, dyslipidemia, and probably you can consider smoking also. So if you have at least 3 risk factors for CAD, it carries another 1 point. Then if the patient is a known coronary artery disease, this is an optional thing only. Suppose the patient has already done a coronary angiography, and one of the coronary angiography details showed that at least having a more than 50% stenosis in the angiography, then considered to be a significant CAD. And if the patient is a known CAD, that adds on to the value, carries another 1 point. And the patient has used aspirin in the last 7 days. Aspirin use in the last 7 days means the patient has been using aspirin. Still, he got an event, means that's a high risk because it shows aspirin resistance probably. That's why aspirin use in the last 7 days is considered to be a high risk factor and carries another 1 point. As far as the presentation is concerned, you have 3 more points to tell in the presentation. For example, if the patient is having severe angina. What do you mean by severe angina? At least 2 attacks in the last 24 hours. In the last 24 hours, he got at least 2 episodes of chest pain in the last 24 hours. Why that is important? Because there is something called like ischemic protection. So once you get a chest pain, the myocardium primes itself to be protected against the future attacks of ischemia, which means in this 2 attacks per 24 hours within the last 24 hours means that ischemic preconditioning is defective. So that's adding on to the risk. So that's why that carries another 1 point. 2 anginal attacks in the last 24 hours. Then if you have any ST segment deviation, I'm not talking about ST segment depression or elevation. If the ST segment is depressed or ST segment is elevated, doesn't matter. We're talking about an ST segment deviation in either way, depression or elevation, which is happening by at least more than or equal to 0.5 millimeter. That carries another 1 point. And if the cardiac biomarkers are positive, troponins are the standard cardiac biomarkers we use. If the troponins are positive, then always, I told you, whenever the troponins are positive, that always indicates a cardiac injury. Irrespective of the situation, if your troponins are elevated, it indicates a high risk of cardiac death and mortality. So that is the reason why troponin positive carries another additional 1 point, because there are a lot of ACS where troponins may be completely negative. I told you, like unstable angina. But even though we don't want that. So if there are 7 points, I told you, 1, 2, 3, 4, 5, 6, 7, all carries 1 point. The total score can range from 0 to 7, hence. So if you have a score of more than or equal to 3, then it indicates a high risk. Less than or equal to 2, it indicates a little bit of a low risk. So based on this only, we are going to categorize the patient into early invasive strategy and probably delayed invasive strategy versus a conservative strategy. Remember, a patient who is having a conservative strategy also can be taken for an invasive strategy, provided there are 2 indications. What are the 2 indications? Suppose if the patient is having refractory ischemia, in the sense if the patient is having refractory chest pain that is not responding to your conservative management, then you have to take the patient for an invasive strategy, of course. Or if the patient is having a recurrent ischemia, which means the patient's pain has settled initially, but once again the pain is coming back and the patient is getting recurrent ischemia. In that setting also, you have to take the patient for an invasive strategy. So further stratification can be classified based on the gray score, whether it is more than 140 or 109 to 140, depending on that you can consider early angiography or a delayed angiography. So fine. So what are the things that you will do in a low risk category? Suppose the patient is having a low risk, what are the things you're going to do? Of course, you're going to give a DAPT, no doubt about that. This is a standard, so there is no difference in that. You'll be giving aspirin plus 1 P2Y12 inhibitor. Preference is towards ticagrelor, but that's fine. Then, of course, I'll be starting with anticoagulation as well. So what are the anticoagulant agents that I need to start? So remember, this is very important. I need to start the anticoagulant as far as NSTAC is concerned, because I need to prevent the development of the thrombus over a period of time, and to prevent the phasic distal embolization from happening, I need to give an anticoagulation, especially in the form of heparin. So what kind of heparin is preferential? Of course, very, very importantly, I have to start low molecular heparin, which has the highest level of evidence. This is backed up by multiple studies over a longer period of time. So low molecular heparin is the standard of choice. We start with enoxaparin, typically at a dose of 1 milligram per kilogram, 2 times a day, BD. That is, BD means 2 times a day, and will start subcutaneously at a dose of 1 milligram per kilogram. So that's the standard dose of low molecular heparin, which is not better, which is much better compared to that of unfractionated heparin. Unfractionated heparin is not used nowadays. Typically, low molecular heparin is the way to go. Unfractionated heparin can be preferred unless and until the patient is having renal injury. Renal failure, your dose of enoxaparin has to be modified. Unless and until you get up in that scenario, you're going to use only low molecular heparin, not unfractionated heparin. There are some alternatives to heparin as well. So like fondaparinux. You have some alternatives to heparin. Some studies tell bivalirudin also, but no. For NSTEMI and stem angina purpose, I don't really use bivalirudin unless and until you're going for a PCA. So I'm going to use fondaparinux as an alternative. Suppose if you really want to know the dose of enoxaparin, let me write here. It is 1 milligram per kilogram subcutaneous 2 times a day. Very, very important. And remember, the dose has to be adjusted in the setting of a renal failure. That's also an extremely important point. Then you have to know what is the fondaparinux dose. In this setting, it is approximately 2.5 to 5 milligram subcutaneous once a day dose. So this is the standard dose of fondaparinux as well. So this is what we refer to as something called a conservative strategy. So this is what we mean by conservative strategy, that is adding a DAPT versus an anticoagulation. Then you have a high-risk patient, so where I know I have to do a invasive strategy. So here also I'll be giving drugs. It's not like I'm not going to give drugs. To stabilize the patient, I need some drugs. What are the drugs I'm going to use in the high-risk patient? So definitely I'll be giving a DAPT, no doubt about that. No, this algorithm is done after the previous drugs in the triage given. No, if DAPT is given already, then that's fine. I'm going to continue the DAPT. That's what I mean here. So you have given the loading dose here. I've clearly mentioned, then you have to continue with the maintenance dose. I'm talking about the maintenance dosing here. The same DAPT only here. I don't know what is the confusion here. I'm going to give that only anyways. I'm going to continue with that. So it's in a DAPT means I'm not going to stop the DAPT there giving a loading dose. I have to definitely continue the next day also. 75 milligram per day of aspirin and probably 180 milligram of ticagrelor, or probably 10 milligram of prasugrel. Whatever you start as, I have to start, I will continue with that. So that's what the DAPT I'm talking about. So if there is any confusion to someone, you can ask, no problem. So DAPT is what I'm going to use. Then at the same time, I have to use an anticoagulation here as well, which is fairly important. Once I use the anticoagulation, what is the type of anticoagulation I'm going to use? So here I can prefer using same, either enoxaparin. I can write low molecular heparin. So I can use a low molecular heparin, that is enoxaparin, which is far better than unfractionated heparin here also. At the same time, you know what are the alternatives here. Alternatives is fondaparinux, but at the same time, remember, you can use bivalirudin also. But remember why we are using bivalirudin here instead of heparin sometimes, because we are going to go for an invasive strategy. So whenever you go for an invasive strategy, you can prefer bivalirudin also. If you do not go for invasive strategy, if you're not going to do a coronary angiogram or a PCI, then in that setting, bivalirudin is not really required. Plus or minus, I can add a GP2B3 inhibitor also. Why I'm going to add GP2B3 inhibitor? Because once again, I'm going towards a invasive strategy. Remember, whenever you go for a PCI, it's better to add a GP2B3 inhibitor, which is having lesser risk of peri-procedure related complication. That's why. So why I've shaded this in yellow? Because these are the drugs we used, especially when you are going for a invasive strategy. So which means patients who are having refractory ischemia or patients who are having recurrent ischemia, in this setting also, you will be adding GP2B3 inhibitors. Why you will be adding GP2B3 inhibitors here? Once again, it's very clear because these patients are having refractory ischemia and recurrent ischemia will be taken up for invasive strategy. I have to add GP2B3 inhibitors. Yes, you have to add GP2B3 inhibitors to DAPT. Anticoagulation is done before or after coronary angiogram. I told you much before. That's why I'm writing here itself. These are all basic treatment. Which year you are in Indra again? Which year belong to? Based on that, I can explain. That's why. You're a final year. That's why you're not understanding this. The idea is because once you do the triage by yourself, you will not ask these many questions. Because you are a final year and you have not got any hands-on training at all. That's the reason why you are having so much of difficulty in getting what's happening here. So remember, this DAPT and anticoagulation is a basic stuff. Basic in the sense, this you will be anyway starting with all the patients of NST-ACS. So there's no doubt in this. So there should not be any doubt. So that's why I told you in the beginning itself. You will start all the patients on this. Then, depending on the risk factor, you will be trying on whether you're going for invasive strategy or whether you're going for a conservative strategy. If the conservative strategies fail, for example, the patient gets refractory ischemia, the patient gets recurrent ischemia, then in that setting, then you're going to go for invasive strategy. Once you know that the patient is going to go for invasive strategy, in that setting, then you're going to add a GP2B3 inhibitor. So that's what I'm mentioning here. So if the conservative strategy fails, now you're going to go for invasive strategy, you're going to add GP2B3A. Suppose if you know at the beginning itself, at the time of starting anticoagulation itself, you know that the patient is needing an invasive strategy because of the very high risk the patient is having, then at that point itself, you can prefer either bivalirudin or you can consider even adding a GP2B3 inhibitors. The final take-home point is very simple. Whenever you think about adding a GP2B3 inhibitor, most importantly, you should think in one way that you are going to do a PCI or you are going to do a coronary angiogram. That's all. And one more area where you can consider invasive strategy is because you have tried a conservative strategy, all right. So then you will do something called a exercise stress test. That's called a EST, or some books will tell ETT also, that is exercise tolerance test. You can give it in any way. We do something called exercise stress test. This is called a pre-discharge EST or a pre-discharge risk stratification, because before the discharge, you need to tell the patient how much they can work, or before the discharge, you need to assess the risk of the patient again, because they have got a major cardiac event. So you do an exercise stress test, ask the patient to run in a treadmill. Usually you do an exercise ECG. So suppose if the patient is having a low risk, according to the EST, which we'll be discussing subsequently, what are the low risk features of EST, exercise stress test, then you can continue with the medical treatment. So whatever long-term medical treatment that you wanted to give, whenever you go for a conservative treatment, conservative strategy, all the patients should be taken for EST before getting discharged. That's simple, not selected patients, every single patient, because it's a major coronary event. NST-ACS is not a simple event. It's a major coronary event, and before getting discharged, you need to do a EST for, in fact, for even STEMI patients, we do a pre-discharge exercise stress test. Because after STEMI or after NST-ACS, one common question that the patient will ask is, how much work I will be able to do? Because it's a very valid question. Because they will be scared that if I do again, I'll get a chest pain and I'll die of myocardial infarction. So how will you tell the patient that how much work you can do, or what is the tolerance of the patient, limit of the patient to work? All these things can be assessed with exercise stress test, which is very, very important for each and every patient suffering from acute coronary syndrome. It has to be done, even though it's not commonly performed in some few resource limited settings, but we have to do. After how many days of ACS we can do exercise ECG? After optimization. That's why I told you it's a pre-discharge one. If you're planning for discharge tomorrow, then you can do today. That's all. So it's when you discharge, it's subjective. How can you tell at what point you will discharge them? You will discharge them at 3 days or 5 days or 10 days. It's up to you, depending on how fast the patient stabilizes or optimizes. So once the patient is stabilized and you're planning for a discharge, that time you can go for a exercise stress test. If it comes as a low risk, then you're going to go for a medical management. If the patient is going to have a high risk, once again, you're going to proceed towards an invasive strategy only. Exercise stress test shows a high risk, then once again, you're going to go for an invasive strategy only, which means you're going to do a coronary angiogram. So once again, the same thing, you will be adding a GP2B3 inhibitor. Exercise stress test is contraindicated in ACS. Okay, Rijo is telling exercise stress is contraindicated in ACS. Of course, exercise stress is contraindicated in ACS. You are not going to make the patient run in a treadmill at the time of ACS. When the patient is showing an ST elevation or patient is showing ST depression and TA inversion in the emergency, you diagnose it as an ACS. Patient is having a chest pain. Why the hell you want to make the patient run in a treadmill? That's absolutely ridiculous. You don't do that. But when the patient has optimized, you have treated them, and at the time of discharge, you're going to do an exercise test, especially if you're doing a conservative strategy. Because why you're doing, because at the end of exercise test, you are going to think whether the patient needs some invasive strategy or not, like whether the patient needs a PC or not, whether the patient needs a cabbage or not. That's what we need to know, because ultimately the final treatment, everything ends up with a cabbage or a PCA only. So that's why, to assess the need, whether they need a PCA or a cabbage, you're going to do for an exercise test. And if it's a high risk, then you're going to go for invasive treatment, invasive strategy again. I mean, in the sense, like, I'm talking about a coronary angiogram here. So, I mean, if you are really confused, because Yaman is asking how we are doing within 7 hours. Okay, if you are confused with this, what my idea is completely different. So you can tell if it's a high risk. Don't think about that, this thing. So we go for coronary angiogram. So now I think Yaman's doubt would have been cleared. Now is it fine? I think Yaman is confused here only. So now this must be fine, right? So if I stop that. So now you're going to go for a coronary angiogram. Cool. Then that's fine. Your confusion is confused. We calculate the two scores, Timmy and Grace. Then if risk is low, why do we do the test? Okay. So remember, the Timmy score and Grace score are done, right? The Timmy score and Gray score are done to choose whether you are going to treat the patient conservatively or whether to treat the patient invasively in the first place. That is the idea of these two scores. These two scores are not to tell whether the patient will not have a risk or whether the patient will have a risk. So it is just to risk stratify. For example, if you go in the road, I cannot assure you that you won't get an accident in the first place. You can still end up with an accident. But if you wear a helmet, I can tell the probability of you dying is very less. So I'm telling, okay, it's better to wear a helmet. But if you don't wear a helmet and go, I cannot confirm that you don't get an injury, or I cannot confirm that you will get an injury. So these are like that. It's like risk stratification. It's like low risk means you are wearing a helmet and going. High risk means you are not wearing a helmet and going. That's all. It doesn't mean that you will surely end up in an accident or you don't end up in an accident. That's all. So it's like that. So it's only to determine whether you go for a conservative management or you go for an invasive management. So once you are decided to go for a conservative management, where you have not yet done the invasive strategy, which means PCA and coronary angiogram is the gold standard. Whatever techniques you do, ultimately you're going to do a coronary angiogram, which is the gold standard. To do or not unnecessarily, this scores will tell you, or the exercise testers will tell you for a conservative treatment protocol. DAPT should patient take for lifelong or only for 1 year? Or after 1 year, only aspirin. Remember, DAPTs, Diary Bogani is asking, sir, kindly check the resolution. I mean, I think resolution is always okay, right? So I'm seeing a good resolution. Is there any other people who are having resolution issues? I don't think so. So resolution is fine, actually. Everything is good. So I think he has to check his screen and the network here. Okay, everyone is having good. Okay, fine. So what else? What are the other questions? Yeah, DAPT. DAPT depends. No, 180p comes to 180p is automated. So that is not based on what I'm doing here. That is your network speed. So that will change automatically. So in this patient, statins are continued for lifetime. So that we'll discuss in the post STEMI or end STEMI care. That's a separate thing where we'll be continuing certain drugs for lifelong. Remember, again, DAPT, dual antiplatelet therapy, depends. So if you are starting for ACS, then you have to give minimum for 1 year. If you're not starting for ACS for some other reason like stenting, then the DAPT itself has a separate protocol which we'll be discussing. Pharmacological stress test done in low risk. Yes, you can do pharmacological stress test also, no problem. So I told exercise stress test just to make sure that you do some stress test, that's all. If the patient is not able to walk, then you can go for pharmacological stress test, not a problem in low risk patients. So ideally, see, finally, what is the take-home point is, because this is something which you're not practicing yet or you're not have seen this, that's why you're having so much confusions. The idea of first categorizing into low risk and high risk is to decide the pathway you're going to do, whether you're going to do a conservative or invasive strategy. Even though invasive strategy is superior, not all patients needed to go for invasive strategy, especially if they're having a low risk according to the Timmy and Gray score. So once you do the invasive strategy, that's all. Beyond this, I don't really need to do an exercise test, because when I do a coronary angiogram, I'm going to visualize the vessel and I'm going to see the vessel. After this, why I need an exercise stress test to further stratify the patient. So that's what you have to understand here. If you're going to do an EST, exercise stress test is to know whether I need the coronary angiogram or not, to go for a coronary angiogram or not. That's why the patient is having a low risk, I'm going for medical management. If the patient is having a high risk, I'm going to take the patient for a coronary angiogram. So that is to stratify whether they need coronary angiogram or not while getting discharged. But the initial low risk and high risk stratification by Timmy and Grace is based on, I used to tell whether the patient needs upfront coronary angiogram or not. To begin with, whether they are having a high risk of death inside the hospital itself, that is what we need. So both are completely different entities. And when you start practicing, it will become completely easier. So after this coronary angiogram, like you're going to have a lot of entities. For example, after this Timmy and Grace score, anyways, early or late, anyway, you're doing a coronary angiogram in this setting. Once you have done a coronary angiogram, you'll be knowing two options. Either the coronary angiogram is not significant at all, you will be just continuing with the medical management, or the coronary angiogram is showing some significant involvement, like a triple vessel disease or a multi-vessel involvement. You can go for some intervention like cabbage or a percutaneous coronary stenting. Percutaneous coronary intervention. So you're going to go for cabbage or a PCA. So this is what I need basically. So even after coronary angiogram, it's not sure that I will definitely do a PCA or a cabbage. To do a coronary angiogram means I need to find out, is there any significant lesion in the vessels? If there is significant lesion in the vessels, I'll be going for a cabbage or a PCA. If there is no significant lesion, then I'll be going for a medical management itself. So I think I cannot, this is a very big, like guideline, like it is a 30-40 page guideline. I cannot compress it further. So I've compressed everything here. The 30-40 page guideline that is given in the ACHA 2018 classification system. So how to treat an end-STEMI unstable angina complex. This one particular table or one particular flow chart will tell you how to, like compress everything in a single flow chart. Clear? So we have not discussed STEMI yet. So don't ask any questions on STEMI. That's all. So this is very simple. I think you can understand. So first step, treatment for everyone. So you're not going to start, deny treatment for everyone. Start treatment for everyone. Start heparin. Start your DAPT. That is for everyone. That is standard. Plus, additionally, you're going to restratify. That is your Timmy and Gray score. Based on that, if you are having a conservative strategy, just manage with heparin and your DAPT. If you're going for invasive strategy, depending on the high risk, then which means you're likely to go for a PCA. In that setting, you can optionally add a GP2B3 inhibitor, or instead of heparin, you can use a bivalirudin if you're planning for a PCA in that setting. Okay, if you're going for a PCA in that setting. Then once your conservative management has failed, then once that has failed, then again, you have to go for a invasive strategy only. In that setting, you have to add a GP2B3 inhibitor. Fine. But if your conservative strategy is successful, patient is having no pain and you optimize successfully, then after the conservative strategy, you can try and do an exercise stress test pre-discharge. If the exercise stress test at the time of discharge shows a low risk, then you can discharge with medical management. If it's showing high risk, then you have to go for coronary angiogram again. So in the invasive strategy, you're going to do a coronary angiogram, of course, but when to do a coronary angiogram again depends on the Gray score. So if it's 109 to 140, you're going to do a little bit delayed. You can wait up. You can do anywhere within 72 hours. If you are going to do an early invasive strategy, then you have to do within 72 hours if the Gray score is more than 140. So anyway, once you have done a coronary angiogram, you will decide whether to do a medical treatment or whether to go for a cabbage or a PC. It's a very short and crisp one, very easy. If at all they ask for exams, you can easily answer, not a problem. But very commonly in exam, the questions will be so easy. The first question they will usually ask in exam is, if they don't want to complicate, they will ask you what is the treatment of NST-ACS. That's what they will ask you. If they ask you this kind of very vague questions, what is the treatment that you use for NST-ACS? You go for low molar heparin. Of course, the examiner is expecting that kind of answer only. If they just ask NST-ACS kind of an ECG, what is the next treatment you will start? Which means the patient, the examiner is expecting to answer low molar heparin. So go for that. So other question they might ask is, depending on the, if they want to go a little bit deeper, they'll give a Timmy score and Gray score, and they will ask you what kind of strategy you follow, whether you'll follow a conservative strategy or whether you follow invasive strategy. For that, you need to know these numbers. Point number 2. Next, the third point, if they want to dig a little deeper, they might ask, so if the conservative strategies fail, which means you have treated with heparin, but still the patient has not responded to your heparin, then this is what it means. So which means it's a refractory ischemia or it's a recurrent ischemia. If the pain continues, then in that setting, you will go for invasive strategy. If they ask you, heparin you are given, still the patient is not responding to chest pain, then what you will do? Proceed towards invasive strategy. And if they ask you what is the next step, can anyone tell? You have given heparin, you have given DAPT, patient is having chest pain. Of course, you are going to proceed towards invasive strategy in this setting. But what is the next step? If they ask you like that, what you will do? What will you answer? They ask you the next step. This is a very common kind of a question again. I mean, you are going to go for invasive strategy. I'm not telling you. What is the next step, but next step is different. Definitive is invasive angiography. Invasive, this thing. Many students have given the right answer. It is because you have to add a GP2B3A. This is what the examiner is going to ask. You're going to add a GP2B3 inhibitor because when you go for an invasive strategy, I told you should add a GP2B3 inhibitor. Refractory ischemia, we come to know after EST at the end of conservative management. I mean, again, you are quite confused. You should definitely not be an intern or a post-intern. You must be a final year for sure. So remember, refractory ischemia means I have a clear-cut evidence of a chest pain itself. If the chest pain is not resolving itself, that's a sign of a refractory ischemia. Why you need a test for that? I don't really think so. That itself is one of the important signs of ischemia. Then what else you need as a cardiologist or what as a physician apart from the chest pain? I mean, that's why I'm telling don't be an investigation freak. Look at the patient also. Clear? So these are the sort of questions that you will be getting. Okay, anyways, I think if you have understood this NSTEMI unstable angina treatment, then we can move on to the STEMI treatment. Can we or shall we? Do you understand this? You need a lunch break. I'll give lunch break in another 10-15 minutes. Don't worry. Once we discuss about the STEMI treatment. STEMI treatment is relatively easier because we know how to diagnose a STEMI. STEMI treatment, as far as STEMI is concerned, you need to know three things. I mean, two things importantly. So how fast you should do a PCA and how fast you should do a thrombolysis. That is called, like FMC to needle time or FMC to a device time. Previously called as door to needle time or door to balloon time. So FMC to needle time means you are going to do a thrombolysis, which means you have decided that you're going to do a thrombolysis. If you have decided to do a thrombolysis, it should be done within 30 minutes. That's all. FMC to device time means you're going to do a PCA. You have decided that you're going to open up the vessel. So if you have decided to do a PCA, which means that's the best thing always, then in that setting, you should either do within 90 minutes or you should either do within 120 minutes. So both are completely, like having a different value. So you can ask that how can you, like have two different numbers? It depends on the situation. So in exam, if they ask what you should answer, you can answer 120 minutes. That will be a best answer according to me. But what do you mean by FMC? FMC stands for first medical contact. So previously it was door to needle time. What they thought is previously the patient comes to the hospital. Once the patient reaches the hospital door, from that time they calculate and how fast you have to do the thrombolysis. That's what they wanted to know. That's what we referred to as door to needle time previously. But currently you don't really need to wait for the patient to come to the hospital, which means the ambulance goes to the patient's own place. So the paramedics are there. So they can themselves find out that it's a STEMI or an NSTEMI. So if you're, training them well. So that's what we refer to as a first medical contact. That's why the door concept has been removed and they made it something called a first medical contact. So these two definitions that you have to know, FMC needle time, less than 30 minutes, and FMC to device time, then less than 90 minutes or less than 120 minutes. That's not chest pain to balloon time. That is FMC. That is FMC to balloon time or FMC to device time. So why they have changed the name to device, not balloon? Previously, they have been doing balloon angioplasty. Like balloon angioplasty is one of the early primitive procedures done in 1980s, where they used to go inside the vessel and in the occluded area, they try to remove the thrombus and they will, because it's stenosed area, so they go there and just inflate a balloon there. Once it gets dilated, they come back. Of course, the vessel is going to go for re-stenosis very fast. So that's a very bad procedure. But to start with, that's formed the basis of our modern PCA. So that time they called it as door to balloon time, but currently there is no balloon, like that is used. In fact, we use the device called as PCI. So that's why it's called as a door to device time currently, or FMC to device time. So there are many changes that have happened in the last 5-6 years. Door to needle, door to balloon has changed to FMC to needle and FMC to device time. And there are sophisticated areas where they do something called a pre-hospital thrombolysis also, which we'll be discussing subsequently. As far as STEMI is concerned, once you have diagnosed a STEMI, you have to see the chest pain duration. That's the most important point. Chest pain duration. You can categorize into many different areas. Whether chest pain duration is less than 12 hours or chest pain duration is in the range of 12 to 24 hours, or if the chest pain duration is more than 24 hours. The chest pain duration is more than 24 hours. It's very clear that you're going to follow only conservative treatment, which means there is no point in doing anything here. The myocardium would have already been dead. So there's no point. So you are only going to manage a very conservative approach. If 12 to 24 hours, we don't have any strong guidelines. You're going to go for an optional reperfusion. Only at certain settings you will do reperfusion. Optional reperfusion. If it's less than 12 hours, you have to reperfuse. It's a definitive reperfusion. This is the first concept that you need to know. Of course, as I told you, the most important treatment of any STEMI patient is reperfusion only, which means you have to open up the completely occluded vessel. That's the goal here. So reperfusion can be done by two techniques. One is thrombolysis, or you can do a PCI, or just I can write a primary percutaneous intervention right now. So these are the techniques that you can prefer. But if you ask which is the best one, of course, I will go for PCI only. Because in PCI, you do a coronary angiogram and you directly see the vessel that is occluded, and you're going to inflate the balloon, and then you're going to push in the stent. So which means that's going to be the best. Lysis is something blind. You don't know whether the vessel has opened it or not. That's all. So this is the idea. Suppose why it's optional reperfusion here. So what do you mean by optional reperfusion? First point is, suppose the patient is having a persistent chest pain. Clear? So remember, ischemic myocardium generally cries in two ways. So whenever you have an ischemic myocardium, this has to be very clear in your mind. Ischemic myocardium can produce symptoms or they can produce signs. So one of the important symptom of an ischemic myocardium is chest pain. So any myocardium that is ischemic will cry out of pain. So that you can consider as that pain can be considered as a cry of the myocardium. So that is why chest pain is considered to be one of the very, very important symptoms in cardiology. You should never ignore a patient's chest pain. That's the final take-home point. It could be non-cardiac, that's fine, but still you have to take it very seriously unless until you are very sure that it's a non-cardiac chest pain. So there are some signs that you can see as well. So some of the important signs that you can see comes in the form of an ECG, electrocardiogram. So where they can show this STT changes based on the injury currents that you are having, which you have discussed already. And at the same time, they can show multiple other signs like heart failure and all these things, which you have to look for. So that's why chest pain is a very, very important sign. So suppose if the patient is having a persistent chest pain even beyond 12 hours, that's a sign of an ischemic myocardium. So I am sure I'm going to reperfuse this kind of a patient. Then apart from that, if my patient is having a persistent ST elevation. So of course, I told you ST elevation is a sign of a alive and a ischemic myocardium. Clear? If the myocardium is alive, not completely dead, and if it's ischemic, then only it's going to produce this injury current. If it's dead, it's no longer going to produce injury current. So that's why ST elevation is also a sign of a alive but injured myocardium. So in that setting, I can go for a reperfusion. Or if the patient is having other problems like heart failure. Of course, one of the important treatable cause of heart failure is ischemic cardiac. So if you open up the vessel, it might improve. So that's why these three are basic standard indications, even after 12 hours, to reperfuse that particular individual. And if you ask me what is the reperfusion technique of choice here, beyond 12 hours, your thrombolysis is going to be absolutely ineffective. I told you after 3 hours itself, the efficacy will be less compared to the thrombolysis that is done within 3 hours. I told you multiple times. But still the window period is up to 12 hours because our environment has not grown to that level that to do within 3 hours. So the patient might present around 4 or 5 hours very commonly. So we cannot keep a strict cutoff of 3 hours. That's why we are having a 12 hours cutoff. But beyond 12 hours, the efficacy of thrombolysis is going to be extremely limited. So in this setting, it's better to always go for a PPCA. PPCA is the best here in this kind of situations. Heart failure, my God, CAG is one of the important things. We have a lot of other areas. You don't know. That is why cardiology becomes difficult when I talk apart from the ECG and the coronary perfusion, because we have never seen cases. That's the most important problem there. So when I go to cardiomyopathy and all, it becomes even more difficult, because these are conditions which you have never ever heard of, like in the first place in your, at least even if you have heard, you have not even had one patient of cardiomyopathy that you would have seen. So that's why the understanding becomes really, really difficult, and there will be so much questions that will come. But anyways, nevertheless, it's advisable to read once again. But anyway, I'll explain also, not a problem. So in this setting, PPCA is the best, because if the patient develops heart failure, Sankhya is asking, then CFG will be difficult. It's not difficult. Why come it's difficult? You have a lot of other areas where you can stabilize the heart failure, like you can give an inotrop, you can do a intra-aortic balloon counterpulsation, then you have axial flow pumps and all are there, like Impella. So many devices are there right now which you can stabilize the patient even with heart failure, and you can easily take the patient for a PPCA or a coronary angiogram. Remember, if there is a reversible cause of a heart failure, for example, if you have a STEMI and you're getting a heart failure because of that, and why can't you really start with why can't you think that the best treatment is going to be the opening up the vessel that's going to improve the heart failure rapidly? Then that's fine. Okay. So PPCA is going to be the best in this situation. So in this condition where the chest pain is less than 12 hours, then you can do a definitive reperfusion here irrespective of the situation. So what you are really going to do is, see where the patient is having less than 3 hours of chest pain, or the patient is having chest pain in the range of 3 to 12 hours. The patient is having less than 3 hours of chest pain. You can even consider pre-hospital thrombolysis. Consider pre-hospital thrombolysis in this setting. So what are the pre-hospital means? While coming in the ambulance itself, you can thrombolyze these kind of patients. What are the indications for pre-hospital thrombolysis? The first indication, there should be no contraindication to thrombolysis. Of course, yes. There should be no contraindication to thrombolysis. And the patient is outside the hospital, which means while coming in the ambulance, the crew should think whether they can shift the patient to a nearby PCA capable facility within 120 minutes or not. So which means that is the FMC to device time. So always they have to think first about the PCA only. Suppose if the FMC to device time is more than 120 minutes, which means the crew is thinking that because of traffic conditions or because there is no nearby PCA capable facility, or if to shift the PCA capable facility will take more than 2 hours, then in that setting they can decide and give a pre-hospital thrombolysis itself. Then that's fine. So suppose if the chest pain is in the range of 3 to 12 hours, then in this setting, you have to see whether the patient has reached a PCA capable facility or not, where the patient is reaching a PCA capable facility or a PCA incapable facility, because there are a lot of hospitals which can offer a PCA straight away upfront, and there are a lot of hospitals which may not offer a PCA upfront. So if the patient is reaching a PCA capable facility, then once again, you can either do a pre-hospital thrombolysis, or you can do you can do an in-hospital thrombolysis, or you can do a primary PCA in this setting. Or if the patient is reaching a PCA incapable facility, in this setting, either you can do a thrombolysis or you can shift to a PCA capable facility. So there are two options, because in this environment, you don't really have a PCA capable, PCA arrangements. So you have to shift to a PCA capable facility. How will you decide whether to do a thrombolysis or to do a PPCA? Remember, PPCA is preferred at any cost. There's no doubt about that. But what are the indications to do a thrombolysis? This is an in-hospital thrombolysis. We are talking about not a pre-hospital thrombolysis. What are the indications to do a thrombolysis, even if the patient is in a PCA capable facility? Of course, first indication, there should be no contraindication to thrombolysis. You know that. Second indication is if the FMC to device time, which means in a PCA capable facility, this becomes 90 minutes. If it's going to be more than 90 minutes, then in that setting, I can do a in-hospital thrombolysis. And why in a PCA capable facility, the patient should have FMC device time of more than 90 minutes or more than 1.5 hours, because it must be a high volume center. It's a practical thing. And many times there will be a PCA that is already going on. And if you feel that you cannot do within the next 1.5 hours or 2 hours, then it's better to do a thrombolysis then later on you can take for the PCA. So understand this flowchart fully, then you can ask the questions. So then if the patient is not present in a PCA capable facility, then there are two options. So either you should have no contractional thrombolysis, or a second indication is if the FMC to device time is more than 120 minutes, which means if the hospital doctors think that it will take more than 2 hours to reach the nearby PCI capital facility, then in that setting, you can do thrombolysis in that particular hospital itself. Not a problem, need not shift to a PCI capital facility. So that's why that initial definitions which I gave you come handy right now. Suppose on the other hand, if you want to do a PCA, this is what always preferred. The only one thing that is needed to do a PCA is FMC to device time less than 90 minutes. If you are already in a PCI capital facility, or when you shift to a PCI capital facility is if the patient is having a FMC device time less than 120 minutes, which means if you feel that you can shift the patient to a PCI capital facility within 120 minutes, then do that. No need to do a thrombolysis. In a PCI capital facility, if you know that you can do a PPCA within 90 minutes, go for a PPCA. That's the best. If that conditions are not satisfied, then only you are going to go for a thrombolysis. Similarly, even in the pre-hospital settings, only if you think that you cannot shift to a PCI capital facility within 2 hours, then only you are going to do a pre-hospital thrombolysis also. If you know that you can shift to a PCI capital facility within 120 minutes, then there is no role for pre-hospital thrombolysis. It's better to shift to a PCI capital facility only. Which means at all stages, we are trying to do a PPCA, but somehow if our cutoff time is not there, if you cannot do within 2 hours, if you're outside the PCI capital facility, or if you're not able to do a PCA within 90 minutes, if you're inside the PCI capital facility, then only you'll opt for a thrombolysis. Otherwise, we don't opt for a thrombolysis. PPCA is same as PCA. I don't know what is PCA. I only told PCA and PPCA. Only 2 things I told you. I don't know what you mean by PCA. I never told a word called PCA till now. PCA means percutaneous coronary intervention. Is it clear, or you need any further clarification for this? I think this must be clear, right? PPCA, I'll come back to that. PPCA is primary percutaneous coronary intervention. That's what we called as a PPCI. So what do you mean by PPCA? If you primarily do, I mean, you are having 2 reperfusion strategies. One is lysis and another is PCA, I told you. If you don't do thrombolysis and you prefer PCA as a primary modality, that's called a primary PCA, which means you have not done a lysis and you're doing PCA as a primary modality. I'll come back to we have not yet discussed the contradiction of thrombolysis, so you should not ask now. Okay. So now it must be clear, right? So is it clear? So whatever I told you, it's neat and elegant, right? So this is a very big, like guideline again. It's going to happen, it's going to be there for around 70, 80 pages guideline. So I've just compressed in a single table, which will be useful for you in exams. So this is how you have to assess whether you have to do thrombolysis or whether you have to do a PPCA or whether you have to shift the patient to a PPCA. FMC needle time is 90 minutes. Who told FMC needle time is 90 minutes? FMC needle time is 30 minutes, which I've told you already. Then how is reperfusion done within 12 hours? Okay, reperfusion, we are talking about the chest pain duration. Okay, chest pain duration is completely different. And this FMC is completely different. That is first medical contact. So chest pain duration can be for 4 hours. But the first medical contact time is 0 time. That is the first time where the patient reaches the hospital or the thing reaches the patient, whatever it is. So what is the confusion between FMC to needle time, FMC device time, and the chest pain duration? We are deciding all these things based on the chest pain duration. These cutoffs are based on the FMC, the first medical, contact time. So I don't see any difference there. I don't see any confusion there. Is someone feeling any confusion, or we can move on to the next level? Okay, move on. That's all. I don't think there is any confusion here. It's very simple. So now we have done a thrombolysis. As I told you, these patients, some patients have received thrombolysis, right? So these patients have received thrombolysis. This patient has received thrombolysis. This patient, some of the patients who have not gone for PCA, these are the patients who have gone for primary modality as thrombolysis. They have gone for primary lysis as a modality because of some like practical drawback where you are not able to shift the patient to a nearby PCA, or even in the PCA center, you're not able to take the patient immediately for a PCA where they needed some stabilization, whatever it is. You're not able to do a primary PCA in this setting, and you have considered primary modality as thrombolysis in certain patients. So these patients, what you have to do, you have to see the outcome. So what is the outcome of thrombolysis? That's really, really important. If the outcome of thrombolysis is successful, then what you will do, or if the outcome of thrombolysis is a failure, it's a failed thrombolysis, what you will do in this setting. So how to assess the outcome of thrombolysis based on whether successful or failure? If I want to know whether it's a successful outcome, then I need to know two things. One is whether chest pain has resolved or not. The patient should not have chest pain, at least considerable reduction in the chest pain after thrombolysis. Second, because I'm dealing with a STEMI, my ST elevation should have resolved by at least 50% from the baseline. So when will you do the ECG for that? Usually we'll do ECG at 90 minutes from the start of thrombolysis. Remember, at the start, from the start of thrombolysis, not from the end of thrombolysis. From the start of thrombolysis, I will be doing ECG at 90 minutes. So in that ECG, if the ST elevation is resolved by at least 50% from the baseline ECG, then I can consider it to be a successful thrombolysis. If not, I'll be taking it as a failed thrombolysis. So if it's a successful thrombolysis, what you're going to do? Still, I'll be taking for a PCA. But remember, this is not a primary PCA, because in all these things, what I'm going to tell now, the primary modality, what you have chosen is thrombolysis and not PCA. So this kind of strategy is what we refer to as a pharmaco-invasive strategy or a pharmaco-invasive PCA. Pharmaco-invasive PCA or a pharmaco-invasive strategy. This is not a primary PCA because I have done thrombolysis as my primary modality here because of some practical difficulties. And next is a failed PCA. If it's a failed PCA for that matters, in this particular setting, I'll be thinking about doing something called a rescue PCA. Rescue PCA, because here I'm actually rescuing the patient from a failed thrombolysis. Because here the primary modality I've used is thrombolysis, not PCA. That's why it should not be called as a primary PCA. So I'm rescuing the patient out of a failed thrombolysis. The thrombolysis has been ineffective and failure. So that's why I'm doing something called a rescue PCA. So when you, even after a successful thrombolysis, still you need to take for a PCA. So how fast you have to take for a PCA is within 24 hours. Within 24 hours, you have to take the patient for a PCA, which means within 24 hours, even if you are in, like Tamil Nadu, you can travel to Delhi for a PCA. Even if that far, the PCA is located, then still you can transfer through air ambulance and also. It should not be difficult in that setting within 24 hours, but it's better to shift the patient for a PCA if you are getting a STEMI, because you really don't know whether the patient is having subacute occlusion still that is happening, or whether the vessel has opened up completely or not. We really don't know. Pooja P. Jain is asking whether pharmacoinvasive PCA is same as a facilitated PCA. I don't know why you are asking this question. Whether you know or don't know, I don't know, or where you studied that word facilitated PCA is what I want to ask now. But it is not the same as facilitated PCA, because facilitated PCA is something which is done within 2 hours irrespective of the outcome. So, but remember, that's very, very important to know that pharmacoinvasive PCA should be done more than 2 hours. After 2 hours, but within 24 hours. Suppose if you don't see the outcome at all, irrespective of the outcome, I mean, I don't want to tell this actually, but because she has asked, let me tell this. If irrespective of the outcome, after a thrombolysis that I used as a primary modality, within 2 hours, if you do a PCA, this is what we refer to as a facilitated PCA. Because you asked, I'm telling. This is a facilitated PCA. Remember, there are a lot of trials. 2 trials have been done, not lot. 2 trials have been done where they did PCI irrespective of the outcome of thrombolysis, which means as soon as the patient reaches the hospital, they did a thrombolysis. After that, irrespective of the outcome, within 2 hours, the patient has been taken for PCA also. This looks very attractive, isn't it? Like initially you do a thrombolysis. Within a short span, you take the patient for a PCA, which means it's a double dhamaga. You do both these things in the same time, simultaneously. So you should be able to think that this must be a very good option for the patient, so that you're doing 2 things at the same time. So if the patient cost is not a problem, means then that should be effective. But no, 2 trials that have been done have persistently shown high mortality in this group, especially if you don't see the outcome, and within 2 hours, if you take the patient for a PCA, that's called a facilitated PCA. And that kind of PCA has shown extremely high mortality. And both the trials that have been done have been terminated prematurely because there is an unequivocal evidence that the mortality was high. So that's why they stopped the trials prematurely, even before the completion. So we don't really do. I actually forgot the names of the trials. There are 2 trials. I'll tell you after the break. Once I give the lunch break, I'll come back to that. I forgot the names basically, Vijay. I'll tell you the names after this thing. And or if you can find out, you can tell me the names also in other way around. So one trial was done with full dose thrombolysis, and the second trial was done with a half dose of thrombolysis, and they did a PCA. So I think I'll give a homework for Vijay. Vijay is going to tell in the afternoon what is the trial that is done with a full dose and what is the trial that is done with a half dose. Okay. So irrespective of the outcome, you do a PCA, that is facilitated PCA. I think you will be able to understand that. Now, currently, we don't follow something called a facilitated PCA. So we do a pharmaco-invasive PCA and you do something called a rescue PCA, if that is the case. Fine. Clear? So these are the options that you have. But if you have primarily done a PCA as a primary model, that is PCA. Oh, Ascent 4, cool. Harshini has found it. I don't know. I completely forgotten, but I read when I was a postgraduate that time. Okay. PPCA is there. So you've done as a primary modality. Okay. Then what? Rescue PCA time limit. Anytime you can do as soon as the ASAP, which means, or I can tell immediately also. The moment you know that the patient is having a failed thrombolysis, why you want to wait for the PCA to happen? So in that setting, there is no option. As soon as possible, you shift the patient and do a PCA done, because it's a failed thrombolysis. What else you can do then? There's no time limit there. Immediately you shift, or as soon as possible. I mean, leaving the practical difficulties apart. So I think this must be a smooth and elegant flowchart. And I think anyone is having doubt in this, how to treat a STEMI, it must be easier, right? All the types of PCA, because I told you many types of PCAs: primary PCA, then rescue PCA, then we have facilitated PCA, then pharmaco-invasive strategy. So I think, is there any difficulty in that? So that I'll tell you the dose of thrombolysis and give you a lunch break. What is the needle time? That is 30 minutes. If you ask what is the needle time, because so many areas, you have decided that the primary modality that you're going to do is thrombolysis. Because you're not able to do a PCA, you have decided that you're going to do thrombolysis at so many steps. So you did a primary thrombolysis also. What I'm trying to tell is, if you think that PCA can't be done, and if you think that thrombolysis has to be done, do within 30 minutes. That's what I'm trying to tell. So if you do decide that the primary modality that you're going to use is thrombolysis, then do within 30 minutes from the time you have decided that you're going to do thrombolysis. This is what we refer to as a door to needle time or a FMC needle time, whatever it is. Which means here you have decided to go ahead with the thrombolysis because there are practical difficulties, so that you cannot shift the patient to a PCA capital facility, or you cannot do a PCA you cannot do a PCI. In that setting, if you want to do within 30 minutes. Understood? Understood or not? Yes or no? Yes. I told you, for chest pain more than 24 hours, you are going to follow only conservative strategy. You don't need thrombolysis, you don't do a PCI. I mean, unless until there are some specific indications like severe heart failure. Outside chest pain and ST elevation, if there is, even if one is present, we should go for rescue PCA. Yes, I mean, it's always any one only. It's not like both. If any one is there, I mean, in the sense, like, to assess the success, like, you need both, which means both are needed to assess the success. But for failure, any one is more than enough. So which means either the ST elevation is not resolving, or if the chest pain is not resolving, if any one is enough, you can take the patient for a rescue PC. Not a problem. Okay. Now, what are the doses of thrombolytic drugs? So lysis, this is a very important one. What are the current drugs we use? So for that, you need to know the drug name. You need to know what is the dose of that particular drug, whether it is weight-based or not. And that's all. That much is enough. So first drug is streptokinase, STK, very commonly used drug in low resource settings, where the dose is standard 1.5 million units in 100 ml saline over a period of 1 hour. There's a standard dose. It is not weight based. It's the same dose for everyone. Then second one is altiplase. Altiplase is also referred to as RTPA, that is recombinant tissue plasminogen activator. So it is a weight-based dose, which means the first dose that you're going to give is 15 milligram as a bolus, then followed by 50 milligram that will be given as an half an hour infusion, and followed by 35 milligram that you're going to give as a 1 hour infusion. So since I told weight-based, but you can argue telling that you're telling everything is a fixed dose. Is it any weight-based thing? So I told you the maximum dose. If you calculate total, it will be coming up to 100 milligram. That's the altiplase vial usually contains 100 milligram. But if you want the first bolus dose as no weight-based regime, if you want to know about the 50 milligram, it says 0.5 milligram per kilogram, maximum of 50 milligram. And 35 milligram means 0.35 milligram per kilogram, which says a maximum of 35 milligram. So usually we give 15 plus 50 plus 35 protocol only if you are planning to use an altiplase. Then we have ritaplase. Ritaplase is not weight based, which means it's used. The main advantage is ritaplase is there is no infusions, which means it's only bolus. And what bolus? It's a double bolus. That's the biggest advantage. Only 2 bolus is enough, where you're going to use 10 plus 10, 10 units plus 10 units of ritaplase. So you start at first dose at 0 minute, and then after 30 minutes, you give another bolus. That's all. Thrombolysis is done. So easy. Clear? First plus first. So then fourth drug is, 10 units means it goes up to 18 milligram. If you ask that question, how much 10 units stands for? 10 units means that is going to contain 18 milligram of ritaplase. Then you have a tenecteplase. These are analogs of RTPA. These are not actually RTPA. They are analogs of tissue plasminogen activator. So once again, it's a no infusion technique. You don't need any infusion, which means it's rapid and you need only a single bolus. Its problem is, not a problem, but it's a weight-based regime, unlike ritaplase, where the dose is 0.5 milligram per kilogram. And the maximum dose that you can use is 50 milligram in this setting. That's the maximum dose that you can use. So this is the dosages of drugs that you need to know. In that, streptokinase dose is really, really important. Multiple times asked question. Altiplase also has been asked 1 or 2 times. And ritaplase also has been asked once in 2016. Tenecteplase has not been asked yet. So you can go through these doses later on. So one question from Indra, 12 to 24 hours bracket if you don't have a PCI. So 12 to 24 hours bracket, if you don't have a PCI, then shift to a nearby PCI cable facility. There, I didn't give any guideline, isn't it? So if you don't have a PCI in an institution, shift to a PCI cable facility. That's the best option. But anyway, thrombolysis, I don't think it's a valid option in that category. Even though India and many hospitals do a thrombolysis still after 12 hours, but I really don't feel that's a viable option. That's taking the risk of the patient's life. So that's not good. So it's better to shift to a nearby PCI cable facility. So after 12 hours, thrombolysis will not work, and it's only going to increase the complication rate. If you do a late thrombolysis, especially in elderly patient, there is a risk of free wall rupture of the myocardium also. Any doubts in this? All these are evidence-based practice. So you might get a lot of doubts because this is something which you're not involved directly. So that is why there will be doubts. You can always read it through once. You'll be understanding it better. And Madhusudan is asking what we do in conservative management. Conservative management means you give DAPT, you give heparin if possible. Because even if you do a thrombolysis, even if you do a PCA, there are a lot of other drugs that you're going to still give. So that we not discussed at all. Even if you give a PCI, you have to add a GP2B3 if you are planning to take for a PCI. And still, even if you do a thrombolysis, still we add heparin. So that's our other drugs. So those drugs you give in conservative management. Tenecteplase dose. We have discussed already, isn't it? Tenecteplase dose is 0.5 milligram per kilogram. Maximum is 50 milligram. Already we discussed about the tenecteplase dose. Clear? Remember, this is an overall approach to do how to treat a STEMI. Despite all this treatment, you should still consider anticoagulation. Irrespective of that, you will give a DAPT, you will give anticoagulation. in the sense like DAPT, we know what you're going to do. And you're going to give anticoagulation also. What are the anticoagulation that you can try? You can try enoxaparin, that is low molar heparin. You can try unfractionated heparin, and you can even try a bivalirudin. Clear? Bivalirudin. All these 3 drugs you can try. Okay. You know the enoxaparin dose. I mean, again, the dose might be like different if you're doing a thrombolysis or if you're doing a PCI. But that is not important. Whether you do a thrombolysis or whether you do a PCI doesn't matter. These drugs have to be given. Definitely, for sure. And remember, anyone, I'm not going to give all the drugs. Anyone, I'll be giving. And at the same time, you know very well that if I'm going to give bivalirudin, the patient will be taken for a PCA. See, remember, it's not like you have to prefer only bivalirudin if the patient is taken for a PCA. You can prefer any one drug, but bivalirudin can be preferred better if the patient is taken for a PCA. That's all, nothing else. Apart from that, I mean, this is not confusing. I mean, to be very simple and straightforward, you can just tell any one of these drugs must be given, irrespective of whether the patient is being done with thrombolysis or whether the patient is taken for a PCA. Naveen Segar is asking if the PCA fails. I don't think the PCA will fail because how the PCA will fail. Suppose you are thinking that in the post-operative state, if the patient is going for a stenosis or a stent thrombosis, I don't know. That's what you are preferring. In that setting, you do a repeat coronary angiogram and find out what is the problem. I really can't understand what you mean by the PCA fail. So because PCA fail has multiple diagnoses, in the sense that's not a PCA fail. I don't know. What do you mean by PCA fail? If you're not able to do a PCA, how you'll not be able to do a PCA? You see the vessel, you stented. How is it not possible? Once you do deploy the stent will deploy, of course. And if there is a problem in the stent, another thrombus. We get another thrombus, do a repeat coronary angiogram, treat like a new MI. That's all. And again, you're going to do the coronary angiogram and decide based on that. So what is the kind of PC that you need to do? So that's why practical difficulty will be there. When is cabbage done? Cabbage has some indications, which we'll be discussing in the afternoon session. Not now. Okay. So now I think it's time to move on to lunch. So we'll go to lunch now. So after lunch, we'll be discussing on the complications of STEMI. Yeah, contraindication for thrombolysis, complications for STEMI, and we'll be discussing on chronic stable angina and other cardiac issues we'll be discussing in the afternoon. So till that, have a good lunch, come back, and bye-bye. Time, it's 2:40 now. Come at 3:45. We'll take 1 hour break. Come back at 3:45.